will have a measurable tool that, let's say it's a blood pressure patient. If they're not supposed to go above a certain range, if they do go above a certain range within the solution, that gives you an intervention opportunity. It'll flag it.
So one of the issues that had happened with some of the prior apps was, you know, there were some apps that had taken blood pressures and they were notoriously low. Like there was a Hopkins study that went and looked at the blood pressures and found that in this population it drastically underestimated. So there was harm caused by that. So my question is, if you have patients who say, I want to use these apps, I want to use these peripherals, and you put them in your thing and you're looking at them and the docs don't know any better, and then have patients who are untreated or uncontrolled and something bad happens, who's legally responsible for that?
That's a good question. And I'll tell you kind of where we are with the application. We will be, Doc is okay, I can tell him this, Bob will be doing our pilot here in Georgia. So we're going to be able to address some of those concerns. I don't have the answer to that. And quite frankly, from device to device, I don't think we'll ever get the answer. But if you're talking just from a legal perspective, your question is very, very important. And from our perspective, from iDirectDoc's perspective, we're going to try to provide a solution that makes sense when you have those types of issues.
My follow-up question is, as a practicing physician, knowing several busy practicing physicians, if you have, like, if you're seeing 20 to 30 patients a day or something like that, you run a busy practice, and you decide, hey, I want to have better connectivity and control of my patients, and I sign up for something like this, and then I get inundated with messages, where do I fit that in my workflow? Like, how is this even, like, workable for a physician?
That's a great question. Now, if you're, that would be a great problem to have if you're a direct primary care physician. I think that'll be borne out. But what I would say to that is, it's a user role-based solution. So if you have a, what is it called? It's not a RN, it's the nurse practitioner. If you have someone that's kind of in the middle that can answer some of those questions that are not like pertinent and life-threatening, you can give them access to your instance to address those types of issues. Because let's be realistic, not every contact you get is going to be life-threatening.
So, I mean, so that if that's the case, though, like if I'm a busy physician and I already have mid-levels in an answering service, then what role does this play?
You have an answering service, but do you have the relationship?
Well,
would you say you have a relationship with all of your patients?
So here's the thing, though. So if, you know, my patients are like, you know, the whole selling point for this is that I would have a better relationship with my physician. Right? But if I'm having a nurse practitioner answer those questions for me, that's an extender, and it's not necessarily the same thing, right? So I would say that a lot of people are like, I want to see the doc, I don't want to see a PA or an NP. But if they're going to be the ones doing that, then I don't know how that's different from having a nurse answering.
Well, you can also extend, I can't tell you how to run your practice, but there's also a way for you to still make that contact. If they pile up, you can schedule those. If they reach out to you, you can then schedule that. I mean, you can have your app teledoc hours, if I can use that terminology. You still have that ability. So we're not trying to replace what you have or say scrap everything else and use this exclusively. That's not the intent of the solution.
Right, I guess I'm just trying to figure out how we could fit that into the workflow for the physician to follow up on the question.
If I can talk to you after, we can.
And Doc brings up a good point, but I think if we think about this, a lot of the busyness of our day-to-day schedules in medicine is driven by distorted demand and the need for people to come in. We're talking about how, of course, this might fit into a whole new ecosystem of primary care where not everything is sign in, give me your insurance card, blah, 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 go through the motions. So a lot of the demand that we see and the busyness that you talk about, that I used to experience and that other doctors experience, is somewhat of an aberration of our system. And of course, when we deflate that, then with new payment methods, paying in advance of care, then we get rid of a lot of those distortions in our daily routine. So that doesn't answer all your questions, and this is a continuum. It doesn't happen overnight. But I think this is, again, a new way of thinking. You know, we have to think different economic terms, different social terms, and different ways of accessing and delivering and paying for care. So this is just fitting into that.
You got a question behind you, Mike?
Yeah. Scott Kalish here. You had a lot of good points, Doctor, and you know, this is all new to me. This is an application that's evolving, so there will be all these little nuances that you address in your office with the the nurse practitioners, the PAs, and who you actually see as a patient that day. So when I go into my doctor's office, I'm expecting to see my doctor, and I never see my doctor. I see either a PA or I see a physician's assistant, but I know that I'm going to be helped. Whether I see the doctor, I see them, the doctor ultimately signs off, and they're going to be trained enough to deal with everything that I come in to see them for. But the point I wanted to make was, you had also mentioned a lot of all the applications out there that you can measure different vitals, blood pressure, heart rate, pulse ox, blood glucose, just all these different things. But I worked at Emory for a lot of years, and there's a Dr. Neil Gordon at a Cantor St. Joe's Hospital. We developed a program called Intervent USA, and basically it was a scientific and evidence-based lifestyle intervention program that used our current body of knowledge in science and medicine to help people correct and manage chronic disease and illness, actually prevent chronic disease and illness, primary and secondary. And as we were developing the program across the country, we were developing these kiosks in malls or shopping centers, and the idea was that the kiosk would have blood pressure, blood glucose testing, whatever the basic details that a doctor needed. And from that kiosk, it would be electronically transported. The data would be electronically transported to the doctor's office. So what I'm seeing here is, if you're the doctor of X, Y, and Z patients, and you have a relationship with them, you will help them understand exactly what they need to take their blood pressure with, whether it's a blood pressure cuff at home, or it's an X blood pressure cuff at a out in a supermarket or whatever. They will know exactly what to take their blood pressure with. They'll know exactly how to test their blood glucose. So it won't be necessarily that they'll be using all these apps that may or may not be valid. The relationship should be, or hopefully will be, you'll know they're taking their blood pressure on using this. It's going to be pretty darn valid, or so it's all evolving, and these are all awesome, incredibly good questions. But I guess if you know exactly what the patient's doing, and the patient has the expectation of exactly what you want from them, then that'll solve so much of the problems.
Thank you. Right here. Okay. Did we answer it, or you just don't want to talk to us?
Question over here. One of the trends lately in the acute care environment is to have patient portals for post-acute care follow-up. So my question is this solution something that's scalable for that and customizable to not just use at a physician practice, but that could be deployed across the system?
That's a great question. The answer is yes. Yes, it has. What you can think of the solution as, it has all of the widgets, and then it's really a use case, right? You determine what use case you want to use the solution for. The primary emphasis was built around the market of the direct primary care because we're trying to get back to the relationship. But if you're using it as a tool to monitor, it's built for that as well.
Thank you.
You're welcome. Jerry? I remember his name. Jerry.
At the risk of using the I word in this forum, meaning insurance,
We like real estate.
okay. Is this reimbursable if the physician practice still does take insurance?
Now, you've crossed the boundaries outside of what I'd be realistically able to answer from that perspective. But again, yes, the the doctor bearing the cost.
So a lot of the health plans now do recognize telemedicine and reimburse for that. And virtually all the self-insured programs, those solutions are available to really very small groups now. Almost all those have some telemedicine component built in, so a lot do now. Probably by the time, this time next year, probably most all will, I would guess. We're in the business of selling health plans.
Okay.
So they do take it.
Thank you for that answer. Now, what was your question? You still don't want to ask me a question?
I guess I would pose, why would we want to get a third party involved? Why would we want to repeat the inflationary spiral that we've seen over the last 30 or 40 years? Let's let the market work this out. And I think we could probably keep the costs down instead of introducing things that arbitrarily or artificially are going to elevate it. So that's my pitch, but you know my bias.
Yes, sir. Another question?
Yes, go ahead.
Oh, sorry.
My question is about the platform. Is when you get the information from the API, does it tell you what is the link for the? So if it's a Fitbit that's sending the information, does the API tell you that it's a Fitbit? Therefore, the doctor is able to see the credibility of that information.
A great question. So the API alone, remember the API is coming from the producer of the that's manufacturing the device. So we'll be able to gauge that. Should there be some? So you're saying if I can just arbitrarily go to somewhere in my admin console and see where this data came from? Hadn't contemplated